Morning, everyone, and welcome to today's webinar session, the webinar special edition webinar by the TB Think Tank in collaboration with the National Department of Health. And today's session is titled Drug-Resistant Clinical Updates. And today's presenter will be from National Department of Health, and her name is Julene. I'll now hand over to Wynette. Thank you.
Good morning, colleagues. I'm not sure if you can hear me.
We can hear you and see you.
Perfect. Morning, colleagues, and thank you so much for joining us this morning. Thanks for prioritizing this webinar. I think I just want to take a moment to just thank the TB Think Tank for facilitating the special edition of the clinical guidelines webinars, which is a preset of the TB coordinators training that's going to be upcoming. So I think before we start off our special webinar, which Ms. Julene Koch will be the guest speaker, I thought it's best that, we just give you a preamble of what the TB coordinators is all about and why are we having this webinar. So if you just give me a moment, I'm going to share my screen. There we go. All right, great. So I'm hoping that by now you'd have heard the buzz about the TB coordinators training that the National TB Program has been organizing, which is really targeting all of the TB coordinators in all the 9 provinces. And this is a special TB coordinators training that's focused at the Meso-Level. And when we say the Meso-Level, we are primarily speaking to the district and sub-district level TB coordinators. But this training is special because it brings in a collaborative effort, because you will be supported by the National TB Program representatives. You will also be co-participating with your provincial TB managers within this training. And we've got a lot of support that we've been provided by partners and technical advisory teams that we work with at National. So we're quite excited about this because I think this really demonstrates the commitment from the National TB Program on capacity building TB coordinators. Over the years, you've been provided with clinical guidelines training. You've seen the National TB Program coming down to your provinces to support you. And I think through these support visits and through the provincial meetings we've had, I think it's been pretty apparent that there is a lot of investment that's required for the TB coordinators. And this is a response to all the challenges that you guys have been facing as you are trying to implement, all of the aspects that are required within the TB program. So this is something that has been well highlighted, and it's been included in the End TB plan, the current one, whereby there's going to be a lot of focus around TB coordinators to make sure that you are feeling pretty empowered, and supported within the work that you are doing on a routine basis. So that said, I thought maybe let me just highlight, why this training matters and what is the focus of this training. So essentially, I think with all of the things that I've said before, but fundamentally, I think the national platform is really acknowledging that TB coordinators are operating in a demanding environment. You're often balancing multiple priorities and you're working with very limited resources. And this is a response to making sure that, we begin to co-problem solve together as one system to ensure that, we are able to effectively make impact within the TB program. So what we did last year in August 2025, we caucused a handful of provincial and Meso-Level district and sub-district TB coordinators. And we came in just to really understand, what are these challenges looking like in their daily practices. And what you're seeing on the screen is a few, sort of quotes, which I think all of you on the call would resonate. Some of them expressed how, sometimes they feel completely, sometimes, their role is not very clear. There's a lot of things that is put on their desk and ways that they need to support, but never really sure on how to respond to some of the challenges. Some people expressed as well that, they do a lot of support visits, but, it's quite exhausting, and zaps out, I think, a lot of your motivation, because you keep seeing the same problems coming back over and over again, despite the multiple support visits and interventions you put in place. Some expressed that, yeah, at some point when they are doing their work at a district or even at sub-district level, they don't have direct access to TIA.net, and they rely predominantly on the data capturer to be able to navigate that system and to, analyze some of the patient level data that we find there. Some people even express that everything is a priority, and sometimes they don't know where to start. They've had numerous quality improvement approaches, and sometimes it gets a little bit confusing. And also, honestly, some of you are still struggle to really understand how DHIS, how they can use DHIS in their daily work. And obviously, some feel like some of the community issues become extremely complex, and you don't really know sometimes how to deal with them. So I think these, I'm just highlighting them so that I can highlight to you that, this training is quite unique because it's focusing on implementation. We are quite confident that all of your clinical training has been provided from national and from provinces, but it really is about how do we translate what is in the policies, what is in the plans, into daily implementation work within our complex environments. So this is essentially what you will be expecting for us to be able to talk about within our training that's coming up. So the goal of this training is, firstly, is to strengthen your leadership and program management capabilities, focusing on the TB program. We are aware that most of you work at, you are supporting both TB and HIV, and that has been factored in. And I think the other thing that we want to make sure that we equip all TB coordinators with practical tools to improve your implementation. So we've tried by all means to package some tools that you can be useful. They're not necessarily the answer to everything, but they will give you, a starting point on how to navigate some of the implementation challenges or things that you have to problem solve within your support visits. And then, we don't want to make it just a one-man's training and we think it's a cookie cutter solution. What we want is a sustainable process of capacity building. So what we want to do at the end of the workshop is that we want to create a TB coordinators community of practice. And that means that we're bringing together all provinces who are working at Meso-Level to break down all the barriers, and we begin to start working together as a collaborative on a continuous basis. So that means actually sharing learnings and continually developing with each other, sharing toolkits and co-problem solving across all the provinces. So this is something that we are seeing as a continued process, and the training and the workshop just becomes essentially the starting point. So the training has actually started, and this is one of the activities that needs to be done. So the training is not just an event; it's a process, and we've already started it, I think, from about last week. The first thing that we need to do, I think, before the training is what you see highlighted there. There's some pre-workshop activities that are extremely crucial and well recommended for you guys to embark on before you actually come onto the workshop. So the first one is the webinars, which is something that we have already started last week. Last week, we offered the drug-sensitive TB webinar, and I think it was shared, the recording was actually shared across different platforms. So I think if you do not have access to that recording, please just let us know, and then we'll be able to share that with you. It's critical that you be able to access that, because I think there were some really good updates and some really good questions that were asked by your colleagues that I think you would benefit from. And today we will be looking at the drug-resistant TB. We will also look at updates and refresh, some of these clinical updates. And I think the reason for this is that, as I mentioned before, the TB training coordinators training is going to be focused on implementation. So there's going to be a very minimal focus on clinical updates. And we want to be able to make sure that when you come to the workshop, you are well-versed and you're feeling confident. And some of those questions that you've had around clinical updates and clinical guidelines can be addressed beforehand. So simultaneously, I think within this week, you will all receive an email in which you will get some really nice toolkits and some exercises on basic to intermediate Excel skills. So we all know that as we work with our TB data systems, we have to export a lot of that data. And as TB coordinators, we have to work with that data to be able to, to see, and analyze, all the things that we actually need. So we thought that it's extremely important that you start to refresh your enemy, have extra practice around some Excel skills, because within the workshop, there's going to be a lot of practical examples and a lot of practical work that we'll be doing with Excel. So I really do encourage you that as soon as that email lands on your inbox, please do engage in a self-paced way on the intermediate Excel, activities that are going to be explained in the email. There's also going to be a leadership skills self-assessment. So essentially, it's a personality test just to see who you are in relation to some of the leadership skills that we are going to delve in at the workshop. Once that pre-workshop is done, which is probably by the end of this week, we begin to embark on our workshop that everyone is quite excited about. It's a 5-day residency workshop, meaning that we're going to have in-person workshops in different provinces where you will come together. Some provinces are going to be paired with others, depending on the geographical location. And all of us will spend about 5 days in a specific location. And some of the things that we are going to be delving in is like things like strategic leadership and program management, using data for decision-making, supportive supervision and mentorship, designing and leading quality improvement initiatives, identifying and scaling good practices, and social and behavior change strategies. So these are all things that we feel are quite relevant for your implementation and things that I think the group of TB coordinators we've been working with have highlighted that would really be essential in optimizing some of the work that they're actually doing. And hence, the third aspect of it is that sustainability plan. I spoke about that community of practice. We will have ongoing peer learning and collaboration. And this will be a safe space for you to reflect and to co-problem solve across all the provinces. And we'll do continuous capacity building initiatives and share innovations that are happening in all of our hubs. So once we do that, this marks the beginning of a more connected and collaborative TB program across all of the provinces. So essentially, that's what we are building together as we start from today. So I'll just flag this for you guys to take note. Official communication is going to come via your provinces into your districts. But I thought I'll just flag for you what has been arranged, and then you can sort of like, diarize some of these dates, and you are just await the official communication that will come to you. So as you can see, the first workshop is going to be in Gauteng, and as you can see, it's actually next week. So we are pretty excited and we're all geared up. And as the months go by, we will be able to engage with each and every TB coordinator. So please do take some time to prioritize this and to diarize this there. So I think I'll stop here and I'll hand over to you, Lena, to take you through the agenda for today. As mentioned, this is part of the pre-workshop activity. Today we'll be focusing on DRTB. So please put on your clinical guidelines hat and you have your clinical questions, things that you've been struggling with around the algorithms or, anything around the TB cascade, around DRTB. Please get that ready and please do feel free to ask any questions within the chat. And then we'll chat back again to be able to close off the session. I'll hand over to you, Lynn.
Thank you so much, Monique, and much appreciated. I'm going to ask you to share my slides. And while Juanita's sharing, I'm going to switch off my camera if you don't mind. I just wanted to say good morning to all. And it's as mentioned earlier on, you know, as district coordinators, there's such a lot that's expected of us. And where do we begin? Where do we start with this whole process? But I think one of the key aspects of being a coordinator is knowing the program yourself. It could be quite challenging if you are not aware of what is happening within the program. So I was grappling a lot as to what do I share with you, how much do I give, etc. But I tried my best to be to share a little bit of everything. So I'm hoping my presentation will be suffice to carry you through, but if not, I'm always open and always willing to assist and support clinically if there's other queries. Okay. As mentioned, we're going to, while Juanita's trying to get the presentation going, we're going to, I'm going to touch a bit on the background of drug-resistant TB to show you where we've been at and where we've come, and then look at the definitions. Once we know the definitions, it will be a bit easier for us to understand what drug-resistant TB and the different aspects of it are. And then we're also going to do some PPL, going into the PPL, the regimen, as well as some of the monitoring, and then looking at the diagnostics, which I hear it's a hot topic that everybody would like to hear more about. Then we're also going to do the monitoring and evaluation. As a program, it is of utmost importance that we know exactly when and how to give the DRTB outcomes, and we're going to touch on the outcomes definition. And then we're also going to look into NIMDR, TB, especially for certain provinces that are really interested, just to show you what we're doing and where we can assist you, and then the clinical audits. So that's good. That's basically the outline of my presentation. Okay, next slide, please, Juanita. You can just move on. Okay, so the background and definitions. So as you're well aware, this is our DRTB guidelines. We've got our decentralization framework, which was published in May 2029, which encourage and it shows us how to do the decentralization. When we decide to decentralize, there's a whole lot of different aspects that's involved. We can't just decide, oh, we need to decentralize because national has said we need to decentralize. We need to look whether we've got access to the drugs, whether we've got access to the laboratories, clinician has been educated and they know how to treat our patients, etc. And this policy framework guideline, it shows us what is required and how do we decentralize. So this you will find online, as well as the clinical reference guide, which is the middle booklet. This is the 2019 reference guide. Now remember, when we brought out this reference guide, we started talking about drug-resistant TB as a whole. We even have our TPT in this booklet. Hence, we're asking you, please don't burn this booklet yet. We need you to keep it because it needs to work in collaboration with the third guideline, which is our updated guideline, which was released in September 23. And the updated guideline has got information regarding the new kid on the block, which is our PPAL. It also gives us other inclusions, such as our adverse events, how to manage and monitor our adverse events, etc. So please, when we look at drug-resistant TB, these are the three guidelines we really have to keep in mind. Next slide, please, Juanita. And then our paper-based data collection tools. As coordinators, we need to know what is the correct tools we need to use when we are assessing or supporting our facilities. We've got our adult DRTB stationery, which is our orange booklet that we've got. Then we also have a pediatric and adolescent booklet, which is white, and you will see there's some differences in the booklets as well. And then our DRTB register, which is available. It is no longer that huge register. It is now in a landscape A4 size. and then our patient identity cards. So people always ask me, Yulene, can you print for us? So Yulene don't have a budget actually, but Yulene asks partners to support and give us budgets. So normally when I update the stationery, I do one print run and then I will send it out to all the coordinators. But if you need to do some printing yourself, please contact me and I will make it available electronically so you have the specs. Next slide, please, Vanit. So let's look at the DRTB types. And this is very important. Remember, our DRTB types has changed with the new definitions that WHO brought in. But it's changed for quite some time. For those people who were still working in drug-resistant TB many years ago, you will remember how injectable agents played a massive role with our DRTB types. But since we have used the oral regimen, the injectable agents no longer are available. So, or form part of our DRTB types of definitions. So what we've got is we've got our rifampicin resistant. So our first section, as you can see, is our mono and poly, but that is the mono and poly to first line drugs, such as our EMB, our INH, and PZA. If you see the line in the center, you will see our RR will feature, and our first section we will have as our rifampicin resistant. So when we refer to a patient as being rifampicin resistant, that means we have received our INH result as well. And that means the patient is susceptible to INH and all the other second line drugs except rifampicin. We cannot deem a patient being rifampicin resistant if our other results are still outstanding. So that is of utmost importance. We need to ensure that our results are back. Then we've got our MDR confirmed. That is when our patient is resistant to INH as well as rifampicin. And then we've got our second section, which is MDR not confirmed. I wish I was doing this session live already because I would have asked you a question as to who do you think should be deemed as an MDR not confirmed? Because a lot of us are still baffled when we say MDR not confirmed. So our MDR not confirmed patients, those are the ones who we have a close contact and the patient is showing signs and symptoms of TB, but we have not received a bacterial confirmation. However, if our contact is MDR, we will automatically treat that patient also as MDR not confirmed. So we always will treat our contacts that are showing signs and symptoms. We will always treat it the same as the source or index case. The same applies for the pre-XDR and XDR. If we have under 5 and the child is showing signs and symptoms of TB, and we're not able to find results for that patient, confirmatory result, but that child is a contact of a patient who's either MDR, pre-XR or XR, we will treat that child the same way as, or in the same regimen as our contact. So please bear that in mind. The not confirmed is the person that you cannot get results from, but is showing signs and symptoms of the index case. And that will be our high-risk population, which is our patients that is co-infected, our elderly, our under 5s, etc. So those are the difference between the confirmed and not confirmed. And then with regards to pre-XDR, we need to have it clear that our pre-XDR is when a patient is rifampicin resistant, with or without INH resistance, and an additional resistance of a fluoroquinolone, which is either moxifloxacin or levofloxacin. Please note, even if the patient is INH susceptible, but the patient is fluoroquinolone resistant with your rifampicin resistant, that patient is still deemed as a pre-XDR. And then our XDR, The definition of the XR will be then a patient who's rifampicin resistant, with or without INH resistance, inclusive of fluoroquinolones resistant, which is amoxifloxacin and our levofloxacin, and then as well as our additional group A drugs. Juanette, you can move to the next slide, please. And this is just a depiction of what I just mentioned now. We've got our drug sensitive or drug susceptible TB, which a patient will be susceptible to the rifampicin as well as the INH. Then we've got our MDR. Patient would be resistant to rifampicin as well as isoniazid. Our pre-XDR, patient is resistant to rifampicin with or without isoniazid, with additional resistance of your fluoroquinolone. And then our XDR, which a patient would be resistant to rifampicin with or without isoniazid, with additional resistance to a fluoroquinolone, plus an additional resistance to either one of the group A drugs, which is the linezolid or the bedaquiline. And you will always see, for a patient to be drug resistant, you will always see the rifampicin. We need to have the rifampicin result to ensure that our patient is then form part of either pre-XR or XR, and then the others just follow as suit. And we're going to look at the sputum results as we go along. Next slide, please, Juanette. So let's look at the BPAL. Next slide. Okay, so in May 2022, WHO announced the introduction of the 6-month regimen, which was the BPAL-M. So with regards to the BPAL-M, it would include your bedaquiline, your protombenate, as well as your linezolid, with additional moxifloxacin if the patient was susceptible to a fluoroquinolone. However, our regulatory bodies in South Africa, SAHPRA, decided to replace the moxifloxacin with levofloxacin due to the adverse event profile, as levofloxacin has less adverse events. And we can see that the levoflox forms part and parcel of the fluoroquinolone family. So hence, we're not using moxifloxacin, we're using levofloxacin. However, in the event that we run out of moxifloxacin or out of levofloxacin, we can supplement it with the moxifloxacin. Just bearing in mind, we need to monitor the patient for QTc prolongation. And the BPAL regimen is supposed to replace the 9-month oral regimen. And currently, we should have phased out the 9-month regimen completely, because in South Africa we only have the 2 regimens, which is our BPAL regimen as well as our individualized regimen for those patients that do not qualify for BPAL. Next slide, please. So let's look at some of the background and why it is of utmost importance for us to phase out the 9-month regimen. You will see if we look at the background, 2011 to 2016, we didn't have a shorter regimen, and our patient were got a 24-month DRTB regimen. If you were RR-MDR, you had to get 5 drugs, 5 different types of drugs with 180 injectable agents. So if you look at that 5 drugs and you work it out over the 24 months, a patient would have gotten 7,200 pills for the duration of treatment, inclusive of the 180 injections. Our XDR-TB patients, they received the same amount. There were 7 different drugs with 180 injectables as well. Then comes 2017, when WHO introduced the 9-month regimen. So remember, in 2017, when the 9-month regimen was introduced, it still contained the injectable agent. And South Africa used the injectable agent for 1 year only and decided, but we can get rid of the injectable agents. So between 2017 and 2018, a patient with RR and MDR TB still received 180 injectable agents, as well as 2,000 880 pills. Remember now the duration has shortened, so the pill burden became a bit less. Those patients who was previously exposed to second-line drugs, who needed to go on the longer regimen, still received 18 to 20 months of oral drugs, which is the 5 drugs, inclusive of the injectable agents for 6 months, and that equated to 180 injections. But as you can see, during that period, the bedaquiline was quite, we were very heavily reliant on bedaquiline, and the XDR-TB patients, their regimen was more friendlier, and they received all oral regimen before our longer RR-MDR-TB patients, and they only received the 3,968 pills, which was even less than the patients who was on RR-MDR on the longer regimen. So in 2017 and 2018, if it was me, I would have opted rather to have XR-TB because I would have gotten less medication with out injectable agents. So because this injectable agent, the oral regimen for the HRTB patients were yielding good results, South Africa took a bold stance to introduce the oral regimen. We stopped giving our patients the injectable agent. So between 2018 to 2023, the 9th oral regimen was introduced, and that's the 7 drugs exclusive of the injectable agent. The patients who were previously exposed to second-line drugs, they needed to go on the longer regimen, and they received 18 to 20 months of 5 drugs, which was 5,048 pills for the duration of treatment. And our XDR-TB patients, which was still doing very well, they received the 5 drugs or oral regimen, which was equated to 3,968 pills. Next, please, Onet. But look what happened. In 2023, in 1st September 2023, South Africa started with the BPAL regimen. And the drugs that was included was your bedaquiline, your levofloxacin, and your protominate. Linezolid and protominate. Just see what protominate did. Protominate got rid of our clofazimine, the high-dose iron H, our pyrazinamide, and our EMB. And it brought our pill burden down extremely. So with regards to the 9-month oral regimen, our patients received 3,038. With the BPAL, with the implementation of the BPAL regimen, our patients received an average of 860 pills. Now, if it was you, wouldn't you rather prefer to go on the BPAL regimen and get rid of the 9-month regimen, as per se? Because that is our whole aim is, as a DRTB program, we need to, none of our patients should be on the 9-month oral regimen. All our patients should have been phased out to get the BPAL regimen. The pill burden is less, the duration is even less, which is just 6 months. Next slide, please. So this is the inclusion criteria. So remember with the oral 9-month regimen, if you were exposed to more than 1 month of second-line drugs, you wouldn't qualify for the 9-month regimen. You had to go to the individualized or the longer regimen, which was 18 to 20 months. However, with the BPAL regimen, the inclusion criteria is any patient that was found rifampicin resistant based on the TB NOT results should go on it, irrespective if you had were exposed to second-line drugs previously. What the staff or the clinician should do is they should track the susceptibility results to ensure that our patients are susceptible to bedaquiline as well as the linezolid and fluoroquinolones. If the patient is resistant to fluoroquinolones, we will just drop the levofloxacin, but the patient will continue with the bedaquiline, protominate, and the linezolid. In addition to those patients, who received their TB NOT results, non-severe extrapulmonary rifampicin resistance, they are also allowed to get the BPAL, and that's including lymphadenopathy, even pleural effusion. So they're allowed to get. And then also patients with extensive pulmonary disease, which will include bilateral cavitary disease with significant fibrosis or scarring or cavities in 3 or more lung zones. They can also have the BPAL regimen. For them, the treatment duration will just be extended to 9 months. So the only exclusion for the BPAL regimen would be patients with severe extrapulmonary rifampicin resistant TB. That will include your meningitis, your pericarditis, osteoarticular rifampicin resistant TB, abdominal or disseminated and miliary TB. Unfortunately, those patients do not qualify to go on the BPAL regimen. They will go on the individualized 18 to 20 months regimen. In addition to that, patients that's resistant to bedaquiline, linezolid, or protominate or delaminate, they do not qualify for BPAL, as well as children under the age of 15, because protominate has not been proven safe for patients under the age as 15, as well as pregnant women. Safety has not been confirmed yet. And you can see the emphasis is on yet. Additional research is being done, and we're hoping that our pregnant women will be able to get people out soon, as well as our children. But be not be dismayed, because our children under the age of 15 and pregnant women, they are also allowed to go on a shorter regimen. We will just replace the protominate with delaminate. Pregnant women will also get clofazimine until the linezolid has been, not the levofloxacin has been proven safe. So that is our inclusion and exclusion criteria. Next slide, please. Our dosage for the bedaquiline dosing, we've got the bedaquiline 100 milligram, and it's given as 400 milligram once daily for 2 weeks, then 200 milligram thrice per week, which is Monday, Wednesdays, and Fridays. So we have written a memorandum for bedaquiline dosing to be given on a daily basis. It is currently with our chief director for sign off. So watch this space. For those provinces that's already practicing daily dosing, please continue. But this is what the original bedaquiline was certified to be given. Protominate is given as a 200 milligram tablet, which is given 200 milligrams once daily. Linezolid is 600 milligram, which is given at 600 milligram once daily. And then our levofloxacin is given according to weight-based. Next slide, please. So I mentioned when we did the DRTB group types, the DRTB types, I mentioned group A's, and I'm sure you guys wondered, for those who don't know, what do I mean by group A? So this is the WHO grouping. And this is how the groups, the drugs is classified according to efficacy as well as safety. So in group A, this is our base drugs that we have, and you can see it's our levofloxacin and amoxifloxacin, our bedaquiline, and the linezolid. This is the drugs for group A. And when we decide to do a regimen or even an individualized regimen, we would choose from the group A drugs first to ensure that our patient has the best drugs in the regimen. Once, if our patient has become resistant to one of these drugs or more of these drugs, we move over to group B, which is our clofazimine and tioridazine. Bearing in mind, in South Africa, we're not using cycloserine because cycloserine's adverse events has proven to be quite severe. Hence, it was a decision that cycloserine is not used in South Africa. So we only choose from between the clofazimine and the tioridazine. And then the next grouping is all the other drugs that's available. And as you can see, I hope you can go through the group C's and group A and B and think to yourself, there's one drug that's not in this list. Have you figured out which drug it is? Let me tell you. It is our protominate, and you can see protominate is not on this grouping. So you will see prothionamide is in, but prothionamide is part of the ethionamide family. The abbreviation for protominate is PA. Okay, so you can see the protominate is not in this grouping. The reason for protominate not being in this grouping is because protominate is not allowed to be used as a standalone drug. Protominate should only be used in combination with albedaquiline and linezolid with or without levofloxacin. Approval has only been gained as such. So if you inspect your folders or if you see that the doctors has given the patient protominate that is not in line with or that is not in combination with bedaquiline, linezolid with or without levofloxacin, please query it because we only have permission to give it with the PPAL regimen. Next slide, please. And this was just an FYI for you guys. So especially if we give the patient the drugs, sometimes it's just good for us to know how much our drugs actually cost per treatment course, especially as managers, so that when in the event that our patients become lost to follow-up, they start and they stop, they start and they stop, or it's just wasteful expenditure. Have a look at all the money we're wasting. So for a patient that goes on bedaquiline, they will need 1 unit or 1 pack because it's got 188 tablets, which is sufficient for 6 months course. For that, our bedaquiline is costing us for the duration of 6 months, 3,148. Look at our delaminate for the 12 course. 23,972 Rand. Now, isn't that a lot of money for patients who sometimes waste it? And that's why it's of utmost importance when we start our patients, and I hope as coordinators we reiterate this, that our patients should have adherence counseling. No patient should slip through the cracks without having the adherence counseling. And we do have the various adherence counseling tools available. We don't have to have a specific adherence tool just for drug-resistant TB. Adherence is adherence, whether it be for drug-sensitive TB, drug-resistant, for HIV. Adherence means we need to adhere on our treatment. Protominate is costing us 6,300. Levofloxacin, you will have to combine the either the 1,000 milligram, which is standalone of 1,000, or you combine the 750 with the 250 mils, and that is the cost of it. And then our linezolid, which is 1,720. So this is just a FYI for us as managers to see how much our drugs in actual fact cost for treatment duration. And with this, you can work out how much it actually costs just for our drugs without the lab costs for a patient who's on drug-resistant TB treatment. Thank you, Annette. Next slide. So this was what was presented at the Union Conference last year. And just want to reiterate, South Africa, who's using the levofloxacin instead of the moxifloxacin. And the reason for that was improved efficacy, safety, and also it helps us with the duration for the treatment. Lynette, can you just go one up again, please? And the predictors of the sorry. So when we did this research, we looked at predictors of poor outcomes, and you can see the patients that we really have to spend on special care is the patient who has had previous DRTB, because their results is really, they've got an increased risk of unfavorable outcomes. Our patients that is undernourished, they've got a slightly higher risk, as well as the patients was HIV positive without being on ART, which is a strong association of poor outcomes. With regards to undernutrition, what we need to be mindful as coordinators, what we need to ensure that our clinicians are aware of, patients with a BMI of less than 18, that is an indicator for hospitalization. So I know in all our provinces, we've got either Center of Excellence or we've got facilities where our DRTB patients should be hospitalized. If a patient's BMI is less than 18, please ensure that the staff or the clinicians are aware that those are the patients that need to be hospitalized because they are at higher risk of a poor outcome. What was really amazing, or what we were very happy of when we did the research, is that nurse-initiated treatment, they had a protective effect, which means that the patients that's initiated by our nurses, their outcomes are actually, it's looking good. I won't say it's really that much improved because we are not here to speak down on the doctors. We are here to task shares, and hence we say for the nurses, because the nurses have got more time to spend with the patients, and also because our information or our treatment is closer to the patient. And just one more up on it. Oh, sorry, just go one more back. Sorry, one back. And if you look at the outcomes, and this is why I can't, other side, sorry. This is why I can't reiterate enough the fact that we need to get rid of the 9-month regimen. If you look at the section with the treatment outcomes, it's comparing the BPL regimen compared to the success rate of the 9-month or oral regimen. And this is data that was the data that we use for one period for a year, where the period was from 1st September 2023 to 30 June. And we looked at the outcomes. And you can see the success rate for the BPAL is 81%, where the success rate for the 9-month regimen is only 70%. The reason being, our loss to follow up for the 9-month regimen is way higher, as well as our mortality, because our drugs is not as effective as the BPL regimen because of our novel agents that we have in there. So I can't reiterate enough that we need to get rid of the 9-month regimen. No patient should be convinced on the 9-month regimen. They all should, in actual fact, be on the BPL, unless they do not qualify and they need to go on the individualized regimen. Next slide, please. Okay, so as mentioned before, we've got 2 regimens only. The 9-month is phased out. We only have this short regimen, which is the 6-month regimen, which is BPL with pregnant and children under 15 years. We call it DDAL, where our protominate is replaced with a delaminate. And then in addition to the 6-month regimen, we've got our individualized regimen. And you will see I'm busy updating the stationery. So when you see the next version of the updated stationery, we will not even have space for the 9-month regimen in the patients folder. Next slide, please. So what is of utmost importance? What is of utmost importance is that we do our observations, and the baseline of observations is of utmost importance to us, especially with regards to our visual acuity and as well as our HP, our ward HP. Remember, if our ward HP is less than 8, we need to either hospitalize the patient or try to rectify that ward HP. Because our patient, alanisolate is an amazing drug. It crosses the blood, the brain barrier, and it is really working very well for our patients. However, because it's given on such a high dose, we really need to carefully monitor it for the side effects. And one of those side effects is anemia, as well as it causes peripheral neuropathy, and also decreases the visual acuity. So at every visit, the patient should have a visual acuity test to ensure that the patient has the vision has not decreased. And we need to check when we do the visual acuity whether the patient is using contact lenses or spectacles, so that we can monitor it as per norm, that we normally do it in the same way when we monitor it. So this is the baseline observation that we do when the patient starts treatment. And what is also very important is to do a pregnancy test, irrespective if the patient is on contraceptive methods. We need to ensure that the patient is not pregnant. So baseline pregnancy tests. And then also, in addition to the baseline observations, we need to do the observations, the visual acuity and certain observations, anemia, ECGs, HP and ECGs at week 2, month 1, and then monthly thereafter. So we've got our schedule that we need to do the observations. Next slide, please.
So we need to do this slide.
Oh, sound, please.
Hi, Yulin. Can you hear me? I'm just
Yeah.
checking in, colleagues. Can you guys hear me?
Yes,
Yes,
But
now we can
hear you, but not the speaker,
Oh, I see.
the
Okay.
presenter, I mean.
All right. Let's just diagnose what has happened.
My apologies. I don't know. I think I was just dropped off. So let me continue quickly. I'm really sorry. So with regards to close contacts, and the reason why I thought this was important is any close contact of us needs to be screened, and sputum needs to be taken. If it's a high-risk patient, The patient should not leave the facility with empty-handed. A high-risk patient should always either leave the facility with prophylaxis, and that is when they do not have any signs and symptoms, or they should, after the specimen was taken, they should go on TB treatment. And that's why we've changed it to ensure that it's like with a high risk and low risk. Please, our patients are missing out on TPT. We need to ensure that our patients get adequate TPT, and also ensure either that they get TPT or be put on treatment, depending on the sputum results. Next slide, please, Vanette. Let's look at the diagnostics. Next slide, please. So we've got our first line, TB naught, and the reason why we call it TB naught, because there's various tests. We have the we've got the Gene Expert Ultra that's done at certain facilities. We've got the BD Max and the Roche. And then we've got our second line Expert XTR, our smear, microscopy smear, TB culture, and DST that we've got. Next slide, please. So let's look at the TB test as per se. So when you see the patient's folder, our initial test is the TB NAT. Now, the TB NAT will give us the information whether the patient is resistant to rifampicin. So when we do for example, the Gene Expert Ultra, it will only give us the result to rifampicin. However, if the BD Max or the Roche is performed, it will give us the resistant patterns to rifampicin as well as our INH. Okay, and then this is where it's recorded. After that, we will do our second sputum, which I'm going to show you in the diagram now shortly. And that's when the second sputum will do the Expert XTR. Now, the Expert XTR tests for 4 different drugs, and which is inclusive of our ethionamide, our isoniazid, our fluoroquinolones, and injectable agents. Now, remember, when we get this result, our patient would have been proven resistance to rifampicin already. We're going to look at the algorithm now to show how it works. So once our patient is resistant to rifampicin, our second sputum will be taken to do the XTR cartridge, and then we will get the next results. And then that will be cultured further. Can we go to the next, please? Let's look at the algorithm. Okay, so this is the DR. Before we go open the others, just one back. Yeah, so this is the reflex, okay? And this is the DRTB reflex algorithm. So now we've got our genotypic rifampicin result with or without our INH results. Remember, we've done our TB NAT, and this is the first block you see. Once our TB NAT has been done, we've got our rifampicin or INH resistance result, and then the second sputum. For those who don't do practice the second sputum specimen yet, we need to take the second specimen, and once we have the second specimen, it will be sent to the lab for decontamination and then also for sedimentation. And we only need about 2.5 moles of good specimen. One down, please, Vanette. So with the second specimen, they will then do, they will check if once it's decontaminated, they will see whether we have a successful or unsuccessful result. This is very important. An unsuccessful result or indeterminate will indicate that we can't do any further tests. Hence, we will probably have to send another specimen. So if we open another one, Vanette. However, if it was successful, we will obviously get our results to see what we have been successful. If the INH and fluoroquinolone is unsuccessful, next, Vanette, then they will do an additional test, which is the midget, and they will culture the results. Now remember, with the Expert XTR, that results take a maximum of 14 days for the results to come back. However, if they see that the INH and fluoroquinolone was unsuccessful, they have to midget culture it, and the midget culture can take up to 42 days before we get the results, unless it's negative. So if they midget culture and we get a positive antigen, then obviously we will get further results. However, it might come out negative. So with the successful results, what they would have looked for is then the INH and the fluoroquinolone. They will either look whether the INH is susceptible or resistant. If the INH is susceptible and the fluoroquinolone is susceptible or resistant, they will do an additional test and check for the phenotypic DST, which will be inclusive of your bedaquiline, your linezolid, and protominate. However, so if we go to the next section, you will see that the INH is resistant and the fluoroquinolone is susceptible. I wish I could use my pointer. Then you will see they will also do a phenotypic test. If INH is resistant and the fluoroquinolone, you can see they will also do. So if you have any resistance for INH or fluoroquinolones, they will do the phenotypic DST, which will give us the results for bedaquiline, linezolid, and protominate. If INH is susceptible, we will also get the INH phenotypic results. However, that will come from the clinical sample that was taken. If MTB is detected, and they will do a further genomic DST, and if it's unsuccessful, they will also go back to the phenotypic. Remember, with phenotypic results, it takes a bit longer. Next slide, please. I hope this is clear. I tried to make it as easy as possible, hence the bubbles were on, to make it easier to read. When you have done your TB NAT and you've got a rifampicin resistance, you obviously have to send the second sputum. And what is of utmost important, when the second sputum is sent, and please, we need to reiterate this to our clinicians, they will need to write, to fill in the TB NAT's episode number. If they do not fill in the TB NAT's episode number at the bottom on your right-hand corner, then the labs might think it's a new test and they will also do the TB NAT, because they don't have gatekeeping to see that a gene expert was, or a TB NAT was done already. So hence it's of utmost important to fill it in at the right bottom corner. We need to write the episode number of the lab. Next one, please. So let's look at the definitions of outcomes. I'm going to go briefly over it and quickly over it, okay? So when we look at the monitoring, we have to determine the clinical response for drug-resistant TB, and with clinical response, we will look at the weight gain, improvement of signs and symptoms, and also the chest X-ray. When we look at bacteriological response of the DRTB patient, it will be monitoring smear and culture. And then also, we need to detect any and manage any side effects or adverse events, and that's active drug safety monitoring. Next slide, please. So let's look at the outcomes. Next slide, please. So outcomes is given, you can move again on it. Outcomes is given for the individualized regimen as well as the 6-month regimen, and it's recorded by the clinicians. And the regimen definitions is the same, whether it be for individualized regimen or for the 6-month regimen. It is the same. Next slide, please. You can move again. And again. So thank you. So what the TB cure is when a patient has had bacteriological confirmation and has completed the duration of treatment. The patient has bacteriologically converted. Now, bacteriological conversion means when a patient has 2 negative sputums, negative cultures. It doesn't have to be 2 consecutive months, as long as there's 2 negative sputums without a positive sputum in between. Now, remember, with a contaminated sputum, that doesn't mean it's positive. That just means that the sputum has been contaminated with any other particles, for example, food, etc. So hence, if the patient has had a negative, a contaminated, and a negative, that is still deemed as culture conversion. So let's get back to the cure. So bacteriological confirmation, duration of treatment has been completed, the patient is doing clinically well, there's no signs and symptoms of TB anymore. and the patient has had at least 2 negative cultures with an additional culture at the end. So if you have a total of 3 negative cultures, that patient is seen as cured. Okay, they must be for no reason. If the patient has had 2 positive cultures, that in between, that means the patient has reverted back, and we need to do further investigations, and the clinicians need to either contact the PCAC or INCAC to find out what needs to be done. Next slide, please. Treatment completion is when there's no bacteriological confirmation. You don't have that 3 negative cultures, you only have 2. That means we have to give the patient a treatment completion. The sum of treatment cure and treatment completion is gives us our treatment success, and that is what we're monitoring, and that is the information we're giving to WHO, the total, which is the treatment success. Then we also need to ensure, and you need, as coordinators, please need to assist us with this, that our patients get recalled 6 months as well as 12 months post-discharge. So once they've been discharged as cured, they need to come back, or treatment completed after 6 months, and 12 months, we need to ensure that they have sustained TB-free. Next slide, please. Last to follow-up, you can continue, you can move again. So what's the last to follow-up? Is when a patient has been without treatment for 2 consecutive months. Okay, I would have loved us to do an exercise online, but we don't have time, so I'm going to ask you just to continue on it. One more down, and one more. Okay, that's enough. So just one back. So when a patient is lost to follow-up, that means the patient must be 2 consecutive months, not 6 weeks. And then we give the patient a loss to follow-up. This is of utmost importance. If the patient has been without treatment for 2 consecutive months, only then we can give the patient an outcome as loss to follow-up. And when the patient, so if the patient has been with me as a clinician on the 28th of March, okay, and I've given that patient a month's supply of treatment, which means that patient will have treatment until the 28th of April. The loss to follow-up outcome will be on the 28th of June. Is that clear? Because that shows the patient has been without treatment for 2 months. Then people always ask me, how can we be sure that the patient has taken the treatment for that 1 month that I've given the treatment? We will not give a patient a month's supply of treatment if we do not trust the patient to take it. Hence, because we trust the patient to take the treatment, we will give the patient the outcome a month after the patient has received, a month later. So the outcome will be given on the 28th of June. I hope this is clear. Many of our patients know that the BPAL regimen is for 6 months because we counsel them. Then they come at 5 months to us. We give them a month's supply. They do not come back for the 6 months outcome, and we make them last to follow up. As coordinators, it's our responsibility to go check to ensure when the patients has been lost to follow up, that it is a true loss to follow up. Because a patient who has been seen at month 5 and do not come at month 6, that's not a loss to follow up, because the patient should have been given an outcome at month 6. So please, if we can, please look and trace and see if we can find patients that is not true loss to follow-ups. Thank you. Next slide, please. Treatment failure is when the patient is not responding to treatment, or the patient treatment has to be stopped and changed to a complete new regimen. Then the patient is a treatment failure. Remember, if a patient has converted to negative, culture converted, and the patient's sputum revert back to positivity, and there's 2 positive sputums after the 2 negatives, that is a treatment failure. But treatment failures, we do not have a lot of treatment failures. We please need to encourage our people to monitor our patients. If the patients are not doing well on TB treatment, it must be picked up before the patient can be deemed as a treatment failure. In whole of South Africa, our treatment failure rate is 3% and less. So we need to ensure that the treatment failures stay below that. Because if it goes higher, then we need to question ourselves, is our drugs actually working for our patients? Okay, so hence we need to be vigilant to prevent a patient being outcomed as treatment failure. If a patient started on the BPL and we do not monitor the sputum results, and only later the patient is actually supposed to be an XDR-TB patient. Remember, that's not a treatment failure. We, as the health department or the health sector, has not followed up on the treatment. So that patient will just then be made as an XDR, and we just continue, because that treatment that the patient is receiving, most of that treatment will be in the regimen, and we just extend the treatment. So remember, that is not seen as a treatment failure. Next slide, please. And then we've got moved coordinators, please. When we move a patient from one facility to the next facility, now moved is only applicable within the same district. When we move a patient from one facility to the next in the same district. When we move a patient, the patient's folder for no reason moves with the patient. If a patient moves from one facility to the next, we write a referral letter. The original folder is always kept at the facility. When the patient reaches the other facility, a new folder needs to be taken, needs to be opened, and the baseline assessment for that facility needs to be done. This is of utmost importance, because when we have litigation against your facility, a duplicate folder or copies is not going to assist you. If I am the judge and jury, I would want that original folder. Hence, please keep the original folder in your facility. You move out with a referral letter. And then if there's any additional information that the accepting facility needs, they can contact you. And the outcome for the moved will be allocated by the facility that has accepted the patient. A transfer out is when the patient has moved from one facility to a next facility in a different district, a different province, or in a different country to continue treatment. Next, please. And then died. Please ensure we have seen crazy things happen in the past where the patient has been given an outcome of died in the EDAR web, and then 3 months later, because the EDAR web is such an amazing system, the patient receives their treatment at another facility. So please be vigilant where this is concerned. If a patient has died, it means the patient has succumbed during the period while they've been on TB treatment for any reason, whether it's a gunshot wound or a car accident, the patient will get the outcome as died. And then not evaluated. I always put this here because we are not looking for any patient that do not have an outcome. All our patients need to be evaluated. This is not even in the patient folder anymore. TB registers, it's the same. We've just decreased it. I'm not going to speak into it. We know the TB registers is just to monitor the registration numbers, etc. Next slide, please. You can, so this is what's nice about the TB registers. You've got the TB outcomes, treatment outcomes in the front page, as well as the ICD-10 codes. Next slide, please, Fonet. And then we've got the patient handheld card, but this is just for the patient. It's like the green cards that they have. We've got the blue card as well. Next slide, please. Next slide. And then just briefly about NMDR, you can move again, and again. One more time here. So we've got different models of care. And we've got inpatient or hospitalization for our patients. And as mentioned previously, patients with that has adverse events needs to be hospitalized below BMI of below 18, etc. Our XDR patients, if it's needed, they will be hospitalized, but XDR is not a criteria for hospitalization. Then we also have our outreach teams. This is clinicians that goes out to the different satellite facilities to see the patients or at farms. And then we have our ambulatory patients, which either comes to our facility, those are the walk-ins. Now, where ambulatory care is concerned, that is where our NMDR initiation plays a great role. We, our nurses, can initiate our patients. Next slide, please. And the aim of NIMDR, which is very important and that we really value, is NIMDR was introduced to the department by the department in 2014, and the aim was to address the clinicians or the physician shortages regarding the MDR initiation. So with NIMDR, it allows the nurses to initiate and monitor uncomplicated MDR TB patients. This is RR and MDR TB patients. It helps and promotes task sharing, and it reduces the physician's workload. It really helps decreasing the workload with the physician. Clinics that are opting to task shares shows, in essence, higher treatment success rate than the national average. And this was an article that was written by Prof. Njika in 2017. Next slide, please. Again. So previously, it was a tedious program to get our nurses initiated or authorized for NIMDR. Now it's a much easier process. The nurses will go through a didactic face-to-face or online training. Thereafter, they will have a 4-day practical session where they will need to complete a practical book. Afterwards, there's an ASCII, and then we will find them competent. So this is so much easier to do. And if there's any districts or provinces that are interested in NIMDR, please feel free to contact me after the session. Next slide, please. And then the roles and responsibility of our NIMDR nurses is just to diagnose, screen patient, collect sputum and review labs, to initiate the treatment, to monitor the patients with regards to their monthly checkups, sputum follow-ups, and manage adverse events. And then also support, very important to support our patients with regards to counseling and on adherence, and provide psychosocial care. We also need to emphasize infection control at the facility as well as at the homes. And then also reporting of the patients, which is on the EDR web. And then collaborate with the clinicians. Next slide, please. And then what we've got is clinical audits on the EDR web, which is amazing. So the clinical audits is to, the aim is to assess the clinical management of our drug-resistant TB patients at the healthcare facility and adherence to the policy guidelines and the updates. Next slide, please. So the orders, as mentioned, there's EDR web audit tool, which will be very interesting for us as coordinators. There's some fields that is auto-populated. And this facility, this audit tool is in line with the paper tool. It's available to be used already, and anybody who's got access to the EDR web can in actual fact access the EDR web tool. So there's different aspects within the audit tool, the same as the paper-based registers. We've got section A to H, and as mentioned there, A is the infrastructure, then we've got B, the human resources, equipment is C, access to laboratory services is D, and then also drug supplies and nutritional support is E, and then hospital indicators is F, and then the guidelines and infection prevention control is G and H. Next slide, please. So when we do the, it will ask you questions where you can say yes and no, and certain fields you have to actually type in the answers to the tool. Next slide, please. So when we do the folder selection, the EDR web is actually random selects the folders. It will ask you your period, when you want to do the period of the folders you want, and then it can either randomly select or you can manually select the folders. So if you put your period in, all your facility folders will come up, and then you can select the folders accordingly. And then the patient files that you will audit will be in the summary. And then when you want to audit the patient folder, you will click on that patient folder number, and it will open on that patient name, and you will do the audit. Next slide, please. And then So the section I to K, that is the folder audit. So section I will look at the admissions and referral to the NGR unit. J will look at the diagnostic and the treatment strategies. And K is the clinical evaluation and patient's response to the adverse events. And we also have a scoring robot. There is 0 to 59%, which will be poor. And then 60 to 70% is moderate, 60 to 79% is moderate, and 80% to 100% is good. So as you go along with the audit, the robot will constantly update and give you the scores. And this is just the example that I use to show you that it will constantly update. It will also tell you when you have not completed some of the questions. So this is the audit, which is a training on its own. Next slide. I think that's my last slide. Next slide, please. And that is it. My apologies for rushing through the last few slides. When we do this training, it normally takes a couple of days to do the training, but we had an hour. So we're open for questions, if there's any questions.
Thanks, Yulene. Really appreciate your time, and it's well noted that this is obviously a much longer training, and you tried to to consolidate it into a few hours. So this is much appreciated. So I think at this moment we'll take some questions. I can see there's already a few hands. Can I also ask Nolwazi to just alert us if there's any hands and questions? But in the meantime, we'll start off with Shirley. Shirley, then we'll have Mr. Blah after.
Hi, good afternoon, everyone. Thank you for the very beautiful presentation. Yeah, it was a good refresher for me. I just wanted to confirm again. You said there will be trainings in the different provinces. I didn't see the Western Cape, and I asked the question, and then I got a response to say KZN dates. Does that mean that Western Cape and KZN is scared for the training?
Hi, Shirley, you were breaking off a bit, but I think I got the gist of your question. So all the dates will be resent to you, and the locations are obviously, as I mentioned, via the province. But I think what has been the key determinant of, which provinces will be paired up is numbers. We tried to make sure that the classes for the workshop are not more than 35 participants, so that we can have a really intimate workshop and obviously, work through a lot of complex things together. So because of numbers, if we basically looked at numbers and the province that has got less sort of like TB coordinators, they will be joined into another province. So as it stands for now, based on all of the logistics that has been stand, Western Cape will be then paid with the KZN group. I think at Oceans are new. So all of these logistics and all and the details to it will be sent to you via email. But as it stands, that's what the plans have been. I hope you can hear me, Shirley.
Yes, I can hear you. Thanks so much.
Okay, awesome. Mr. Blah, please unmute and share your question.
Thanks so much, Winnet, and thank you so much, Yulene, for that comprehensive presentation. I agree the time. We've got a lot of background noise. There are people who are not muted, Winnet. I hope you can hear me.
Yes, we can hear you. And please request that please just check if your mic is muted so people can be audible. Thanks for that, Mr. Blah. Please go ahead.
No, thank you so much, Julian. Just two questions from my side. One, it looked like that was an updated NHLS lab form requests form. Can you please confirm, is the lab form updated? And if so, when can we get it as provinces? Two, we'd like you to put it explicitly in your outcome definitions, especially the area of we've got a lot of background noise. I'm not sure. Am I audible?
I'm just checking Mr. Blah, who might not have their mic on. In the meantime, please do go ahead. We'll check with that. Nolwazi,
Sure.
can you also help me
Yes,
verify?
they're muted. They're muted.
Thanks.
No, thanks, Vinette, colleagues. So the last one is unique. Can you just also put in your bullets, because it was not explicit, especially the movement of the folder. For me, it's critical information for the coordinators out there so that we can convey a consistent message around you having to move the patient with the folder to the receiving facility and no copies. Thank you so much. Those were my few questions.
Thanks. Yulene, would you like to respond around the lab form?
Yes, so remember with the different laboratories, they've got different lab forms because they work differently. But what I can do is I can request that they use the lab form that was presented because it's so much easier for us. Remember, we've got various laboratory forms, whether it be for hospitals or primary healthcare facilities. But that lab form, I will speak to Farzana as well to ensure that the laboratories get that lab form and that they, in actual fact, send it out when there's request available. With regards to the movement of the folder, certainly, Mr. Blount, I will add it to the presentation to make it explicitly clear so that people can adhere to that guidance. Thank you, Mr. Blount.
Thanks, Yulene. We'll move on to Job Mokwera. Please unmute.
Yeah, good afternoon, colleagues. My name is Job Mokwera from Northwest Province, TB Program Manager. Thanks so much, Chair, and thanks so much, Yulene and everybody in the platform. Thanks, Yulene, for such a beautiful and powerful presentation. Maybe mine is just a general observation. I've noted that we do have a patient that are age resistant only, but in most of the time, this group of patients are so everybody's so quiet about them, either in the monitoring, capturing, or even monitoring their outcomes. So I just want to check whether is there any reason why are they being isolated because they form part of the program. Thanks so much.
Juanita, I don't know if you got that, but the group of patients that was mentioned, that's when Mr. Mokwera broke up. So I don't know which one he's referring to, please.
Mr. Mokwera, do you mind just repeating your question? For Yulene, she said that you broke a little bit.
Oh, okay. Thanks so much. No, I was just saying I want just a clarity. I've noted that majority of our resistant TB patients, as you look at the DRTB type, they've been categorized and they are being monitored, and even their outcomes are being monitored. So I just want to check with this small group of people that are resistant to NH only. Is there any reason why are they not being monitored so closely, and why their outcomes are not so monitored and maybe evaluated, or is there any reason why this group of NH patients, not so much attention is being given to them? Thanks so much.
Thank you, Mr. Mokwera. I got it now. So with regards to the INH patients, so we are monitoring them closer now, and training has been done. So the INH patients are being monitored in this DSTB patient folder. They've got their folder and their section that they need to be monitored. In addition to that, all INH patients should be captured in the EDR web now. So we will be monitoring INH closer now because we need to report on it. And please, if you haven't received or you're not aware of the training that has happened, please let us know so that I can speak to the colleagues to ensure that Northwest will be getting the necessary training. But thank you for that.
Thanks, Yulene. It looks like there aren't any hands so far. The webinar was supposed to close at 12:30. So I think we won't take too much of your time, but I think we'll take an opportunity maybe just to say thank you to everyone for making the time. It's quite pleasing to see our first webinar. I think we had just over 40 people, and today we've got just over 80 people. So that's really great. But we are expecting to reach about 210 TB coordinators. So as mentioned, we will be sharing the webinar recording via email. I note that in the comments that the last recording didn't seem to reach everyone. So we'll coordinate with the TB think tank and also our administrators to make sure that all of the people who are on this call receive the recording. So I think do expect the DSTB recording and also the DRTB recording. So obviously there was a lot that Yulene unpacked. And, obviously it's a day's training, and she tried to, to put it all into one. So thank you so much, Yulene, for, doing such a fantastic preparation for us and supporting the TB coordinators training. So I think the next steps really is just that we are now looking forward to start the workshops, those residency workshops I spoke about. So the first training is starting next week with Gauteng. So please look out on your WhatsApps and in other communication to see how that's going and, how people experienced it, so that you can look forward to your workshop as it will be upcoming. So we're looking forward to this journey with you all. And I think, a lot of things have been prepared, and I'm hopeful that all of you are looking forward to it. So in the meantime, please look out for our emails that gives you more details around the TB coordinators and also around the pre-workshop activities that I mentioned before, which is going to be in Excel. Self-paced sort of like exercises and videos, and also the leadership self-assessment through a personality test that you will do. And then once you do all of those things, you'll be well and ready to come and enjoy and learn at the workshop. So with that said, I just want to say thank you again, Yulene, for your time, and thank you to each and every one of you for attending this morning. So have a good afternoon, and we'll chat soon and see each other soon. Bye.
Bye. Bye-bye. Thank you.
Thank you. Bye.
Bye. Thank you. Bye.